All right, you guys, this is the OB final review, and due to some last minute changes, it's only me tonight, but if you have any questions, I will still be at the Zoom meeting a little bit later after you guys review this PowerPoint. So antepartum. So the phases of the menstrual cycle, my period sucks immensely. Menstrual, proliferation, secretory, and ischemic phase. Ovulation occurs 14 days before the next menstrual cycle, and ovulation is when the women are capable of getting pregnant. And then sperm live around 3 days, and eggs live for 24 hours. I would be more aware that implantation occurs 6 to 10 days after in the uterus. Yeah, just be aware of that. So fetal development. Again, ovulation occurs 14 days before the start of menstruation. The pre-embryonic phase is fertilization that occurs 24 hours after ovulation. The implantation in the uterus occurs 6 to 10 days after fertilization. And then in the embryonic phase, that's when teratogens are most likely to harm the embryo and cause long-term defects or a miscarriage, most likely. It's a zygote for 2 weeks, which is the stage that comes before embryo. It's an embryo from 2 to 8 weeks, and then it's a fetus from 8 weeks to birth. All right, so fetal circulation. I'm just going to go over a brief overview. If you have any questions for me, you can join the Zoom. But remember that there's 2 arteries and a vein. The placenta is what revitalizes the blood with oxygen. So remember artery away, so it takes the deoxygenated blood from the fetus to go and get reoxygenated. The vein takes the oxygenated blood to the baby, and then it enters through to the right side of the baby's heart, and then it goes into the left atrium, which goes in the left ventricle, just pumped out of the aorta. The most oxygen-rich blood goes to the brain. The least oxygenated blood goes to the rest of the body and then makes its way to the arteries to go be reoxygenated. 2 arteries, 1 vein, and that is one of the main things that you need to know. The foramen valley is the one that is the hole between the left atrium and the right atrium that allows the blood to go through. And then I'll talk a little bit, if you guys want to know more about the ductus venosus or the ductus arteriosus, I will talk about that in the Zoom if you have questions. All right, so fetal development, there's preterm, 20 to 37 weeks. I would more know that late preterm, so early term, full term. So you definitely need to know late term. Early term and full term are the 2 that just know that term is 37 to 40 weeks. And those are just some terms that I'm sure you guys are aware of at this point. Let's see. Yeah, and remember that abortion, so those are pregnancies lost before 20 weeks. So signs of pregnancy. So the presumptive signs are the ones that the woman is going to notice, like, oh, I'm not getting my period. Those are subjective, like symptoms. Nausea and vomiting. It's like, I feel nauseous today. I feel fatigue. I'm noticing breast changes. And those are things that you yourself would notice. Probable signs are signs that you are most likely or more likely to be pregnant, and they're objective and they're measurable. Like the pregnancy test, that is a very highly likely sign that you are pregnant. However, there are false positives, so keep that in mind as well. So the Hagar sign is a softening of the uterus, and the Chadwick sign is the blue discoloration. So I would definitely keep those 2 in mind. The Goodell, one second. So yeah, it's a softening of the isthmus. So that's what the Goodell sign is, which is, I could not remember for a second. Yeah, so just keep that in mind. And then ballottement is that bounce. If you think of the 2, if you check for fetal placement in the vagina, then there should be like the bounce back. So that's ballottement. A positive sign is diagnostic. You actually see the embryo or the fetus. So that's fetal heart tone, ultrasounds, and fetal movement is undeniable that you are pregnant and you were actually looking at the baby. Definitely know Nagel's rule, last menstrual period plus 1 year minus 3 months, and plus 7 days. All right, and here's just a picture of changes that happen in pregnancy. Oh, oh my goodness. How do you get rid of that? Sorry, I could not get rid of that without Xing out. Okay, so important milestones for the fetus. Um, so definitely know that the heart begins to pump blood at 8 weeks. No, for 12 weeks, the sex is able to be determined. Keep that in mind. Yes, the kidneys produce urine. And 16 weeks, the meconium is in the bowel. Vernix and lanugo should cover the body. Definitely keep in mind that you cannot bathe the fetus immediately because the vernix is actually protective. So keep that in mind. So 28 weeks, fetus can breathe, swallow, regulate temperature, surfactant forms in the lungs, which allows for that maturity, and then the fetus can hear. Um, and then the rest I would just be aware of. So maternal antibodies provide immunity up to 6 months till the baby's immune system is sufficient. And reminder to give betamethasone if they don't have enough surfactant when they are born if it looks like they're going to be born preterm. Okay, some more important milestones. So yeah, uterus changes, all those signs that we talked about in those 8 weeks. In the 12 weeks, Braxton Hicks contractions, those are like the false contractions. Yeah, the placenta is fully functioning, producing hormones. The rest of this I would just keep in mind. At 20 weeks, I would know that the fundus reaches the umbilicus. The postural hypotension may occur. And know that the bothersome things that women face during pregnancy are like the leg cramps, nasal stuffiness, constipation, and varicose veins. And then diastolic blood pressure starts to increase, and I would just be aware of the rest. And some ways to nursing education for moms facing uncomfortable symptoms would be eating those small, frequent meals, avoiding fatty foods, no hot tubs, saunas, or steam rooms. And to prevent a UTI, you want to make sure that the mom would be drinking 3 liters of fluid a day, voiding every 2 hours, void before and after sex, and wipe from back to front. And they're going to do some screening for genetic defects or any other defects that might occur in this time. And yeah, encourage the mom to be active. You want to prevent DVTs, and I'm sure you guys have heard a ton about DVTs. You want to help constipation with a fiberful diet, like raw fruits, veggies, cereal with bran, and again, that 3 liters of fluid a day. So that's just important for multiple reasons. Yeah, the diastolic blood pressure increases at the 24 to 32 weeks. You want to do that blood glucose testing at 24 to 28 weeks. If the mom is experiencing hemorrhoids, you want to give them a sitz bath. You would give them topical anesthetics and stool softeners as prescribed, but I would definitely keep in mind the sitz baths. Let's see. Yeah, that's about it for this slide. So prenatal care, so the visit schedule, I would definitely be aware of it. Every 4 weeks until 28 weeks, you want to visit. Every 2 weeks at 28 to 36 weeks, and then every week after 36 weeks. Know the normal weight gain, and you don't need to know the calorie increase exactly, but no folic acid prevents neural tube defects, iron prevents anemia, always adequate fluids and protein, and then yeah, and then milk. All right, so some of the prenatal tests. Let's see. So the ultrasound can is usually done around 20 weeks, and then they can determine gestational age. The ultrasound, um, the ultrasound can also at the first it can be done when the fetus is small, first to second trimester. Um, and then so it says have so you can have the mom drink 3 to 4 glasses of water and then come in with a full bladder to help the uterus be supported for imaging. So for the ultrasound. So put a pillow behind the neck and knees to keep the pressure off the bladder. Um, but that's just a little background about it. But I would just know that you can determine gestational age with it. Chorionic villi sampling, know that you can do it for genetic testing, and it's usually done at 8 to 12 weeks. The amniocentesis, it tests the fluid, and we'll talk about the fluid a little bit later. Usually done by 14 to 16 weeks. The non-stress test, I talked about a little bit about this before. So 2 accelerations of 15 beats per minute every 15 seconds. For 15 seconds, sorry. And a reactive non-stress test is good. A contraction stress test is 3 contractions every 10 minutes. Um, it's a negative result for late or variable decelerations. That's good. So if it's negative, that's good. The biophysical profiles, and remember that that's that scoring that you need at least an 8 on. So just be aware of that. All right. Blood typing and incompatibility, we talk a little bit about Rh factor and that ROGAM. So if the mom is Rh negative and you have an Rh plus fetus, if the dad is Rh plus and the mom is Rh negative, the fetus will most likely be Rh plus. So then you have that risk of the mom's blood attacking the fetus's blood, which is why we give the test to determine if ROGAM needs to be given at 20 weeks. So it should be given at 20 weeks and after birth. There could be vaginal bleeding or trauma, or if there's an invasive procedure, something like that. And ABO blood typing, just be aware of that. So intrapartum. So the 5 Ps of labor, I go pretty much into depth on my last slide, but remember the 5 Ps. Know that the lie, the presentation, all that is very important. The head needs to be facing downwards. The sorry, um, the head needs to be facing downwards, and then breech is where the bottom and the legs are first, and then remember for the powers, you want the moms to be vocal during pregnancy because you want that continuation of oxygen. Um, Squatting is better, so it opens the pelvis. So positioning is very important, station engagement. Um, see, the best pelvic shape is gynecoid, so I would know that. And then you have the primary powers, which is the contraction. Secondary is pushing, and then we talked about the position, which is the like the squatting. And psychological is the person's stress, is the mom, and what does that inhibit the labor, and how can you ease her stress? So the stages of labor. So the first stage is that latent 0 to 3 centimeters, active 4 to 7, and then transitions 8 to 10. And then if this is their first time giving birth, usually the second stage takes 1 to 2 hours. But if this is multiple births for them, it can be less than an hour. The third stage is the delivery of the placenta, and I talked about before if the placenta isn't delivered within that time, they can start suspecting placental fragments, or if another problem is occurring or some sort of bleeding, you would want to look for that. And then the fourth stage, we're watching the mom for at least 2 hours after birth. And after the water breaks, and just to let you guys know, after the water breaks, you're going to want to look at the amniotic fluid, coat or taco, so clear pink fluid. You want low odor. You want to look at the amount. Is there too much? Is there too little? And then general time. Know the time frame for that. All right, the cardinal movements, just be aware of this. You don't have to memorize anything, but just be aware of these. All right, true versus false labor, and so cervical changes is the biggest thing for discerning cervical changes versus true labor versus false labor. So keep that in mind. So also for true labor, the pain in the lower back radiates to the abdomen, but in false, it's the pain in the abdomen, but not the lower back. The contractions are irregular, and with true labor, the contractions are rhythmic. And I would focus on those because those are big differences. All right, so pain management, non-pharmacological measures, I would definitely be aware of this. So position changes, breathing, imagery, touch, hydrotherapy. Um, those are things that you really should be doing for the mom if she's getting stressed out, whether it's emotionally, physically. Do what you can to calm and ease her anxiety. Um, So pharmacological, it does depend on the stage of labor and method of birth. Is it a C-section or is it vaginal? Systemic analgesia. So know that respiratory depression is like the biggest thing. You want to make sure that if you're giving any type of analgesia, you want to look to see if their respiratory rate is still where it needs to be. Hypotension with pregnant moms can be very common if you're not careful. Itching and urinary retention. And if there is urinary retention, we are going to have to do a straight cath. Have Narcan available, which would reverse that respiratory depression. Um, so yeah, then there's nerve block. So then you have spinal, which is used for C-sections versus epidural, which is used for vaginal. Again, that hypotension, the respiratory depression, you have nausea and vomiting. You might want to give an antiemetic before if you know that this is going to be if you know they might experience nausea and vomiting as a side effect from the medication. And considerations, you want to give a fluid bolus beforehand to try and prevent that hypotension before giving meds or epidural or anything. Make sure they're in the right position, and if they need a Foley because of if the person gets the spinal anesthesia, they kind of lose that that control to release their bladder. So maybe they would need a Foley. Then yeah, possible assisted or prolonged delivery. All right. So shoulder dystocia. Remember that knee chest position or McRoberts maneuver if they're experiencing that, and that suprapubic pressure. Shoulder dystocia is very distressing, so you want to make sure that you act on that quickly. And they're going to need an immediate C-section. Cord prolapse, so due to fetal unengagement, it can happen long cord if they're breech. If there's too much fluid pressing on that cord, so you're going to want to move the fetus off the cord. I think Stephanie might have talked about literally maybe lifting the baby's head off the cord, and then yeah, the Trendelenburg position. The amniotic fluid embolism, she mentions that this happens very quickly. Like the signs and symptoms, it can happen like in like a few seconds, in like a minute. So you need to react quickly if you start noticing the breathing problems, because that can immediately lead to cardiac arrest, EIC. Watch out for these. Then uterine rupture, and that is obviously an emergency because the mom could bleed out very soon, very quickly. Oh, and just so you guys know, during a cord prolapse, you cannot deliver vaginally, and you will hold the baby off the cord until a C-section is available. All right. So external fetal monitoring. So Leopold's maneuver, you are detecting the fetal presentation. It's not invasive. You're more hands-on from the outside, determining where the baby's head is. It's relatively older school method of doing it, but it is obviously cheaper than an invasive test. It does not measure contraction intensity. The ultrasound transducer along the back of the fetus, and then there's a toco transducer at the top of the fundus. So there's a picture here that shows where it goes to detect the fetal movements. All right, so fetal monitoring, remember, you want to determine the baseline. If you could draw a line through the middle, where is that So the average heart rate in a 10-minute period, remember the normal ranges, 110 to 160, tachycardia is above 160, bradycardia is below 110. And the difference between periodic versus episodic. So that you have that, I talked a little bit about it before. So periodic is with the contractions, and episodic is not with the uterine contractions. If there are changes that are consistent with, if there are changes that consistently happen with the uterine contractions, that would be periodic changes. Episodic changes is that they're independent of the uterine contraction, so they don't affect what the baby's heart is doing or what they're monitoring or their changes. So they're just separate. One is dependent and one is not. Acceleration, so yeah, 15 beats per minute increase for at least 15 seconds. So those are fine. Step 2, so determine the characteristics. So what's the frequency, the duration, intensity, and resting tone? So the frequency is from the beginning of the contraction. The picture describes it well here. The beginning of the contraction to the start of the next one, while duration is from the start to the end of one contraction. So you'll see like the duration is shorter than the frequency. The intensity is, that's the only way, that's what you need to be able to tell from internal monitoring or palpation. And then resting tone, that's also palpated, and you want to make sure the uterus rests between contraction, because you don't want the muscles to get too strained, and because they need to be able to contract for the rest of the labor, which kind of goes back to the powers that I was talking about, whether they're sufficient or not sufficient. All right, step 3, so note variabilities, acceleration, decels. So variability, we have the fluctuations in the heart rate. So that indicates the functioning of generally the central nervous system, push and pull of the sympathetic and parasympathetic nervous system. And that is the most important indicator of fetal well-being. So moderate's where you want to be. Minimal is like if the baby has much less movement than they need, and then absent is either check where the placing of the cord is, or you might risk a lot, or the fetus might be under very serious distress and they're not picking up any activity at all. So that is the most important indicator. Keep that in mind. Is affected by drugs, gestational age, sleep cycle, and fetal hypoxia. So the drugs, if we talked a little bit about it, but pseudosinusoidal is the one that you'll see with like narcotics, and it'll be that sinusoidal, those waves, but it won't be exactly that, because it is caused by the drugs. And then, yeah, sinusoidal is severe fetal anemia or hypoxia, or the mom is like taking narcotics. So accelerations. So yeah, that increase of 15 beats per minute for at least 15 seconds. Change in the fetal heart rate over 2 minutes would indicate that baseline change. And yeah, it's associated with fetal movement, well-being, adequate oxygenation, because there's no problems with this. And if you guys want to take a minute to read the strip, or if you guys are confused about the strip, you can pause now. Otherwise, I'm going to say the answer. So the baseline is about 120, and it has moderate variability and with accelerations. So decelerations. So early decels are absolutely fine. They can be recurrent or intermittent. And then early decels, that indicates like fetal head compression, and early decels are just fine. And they should mirror the contractions. And you want to make sure that it's either mirroring it, or if it's a little before, that's fine. So there's no intervention with this. Late would be that uretoplacental insufficiency or maternal hypotension from the epidural or other placental problems. And just remember veal chop, and you guys will be fine with this. Okay, deceleration's continued. So also late decels, yeah, that indicates prolapsed cord or cord compression. It is not associated with the uterine contractions. And if they're abrupt, if they're V, U, or W shaped, that's where you are going to want to, your first intervention is going to be to turn that mom, if you start to see some of these, that then you're going to turn on their oxygen, 10 liters per minute. Intravenous fluids, you might want to push a bolus, stop the oxytocin, and then notify the provider, note a vaginal exam. But you're going to want to turn them, see if it changes. If it doesn't resolve, then you keep intervening in these ways. So prolonged decels, that is also cord prolapse, uterine hyperstimulation, severe maternal hypertension, hypotension. I keep saying hypertension. It is most definitely hypotension. And yeah, you want to, and you still want to intervene in these ways. They last between 2 to 10 minutes. They can be any shape. That is just a general dip from the baseline. Yeah, and that indicates a prolapse cord or the stimulation of a hypotension. All right, veal chop. Memorize this because that's going to come back where even after this class, and this will really help you guys, just as long if you don't have it memorized already. So the 3-tier system, again, be aware, category 1 versus category. So if you know category 2, so it's anything that's not 1 or 3, absent variability with tachycardia, and then category 3 is just this very abnormal, while category 1 is normal. So as long as you know that category 1 is normal, category 3 is abnormal, and veal chop, you should be fine with this. So the newborn. All right, I can't stress it enough, but definitely you take the APGAR at 1 and 5 minutes. Know the APGAR. Actually know what they stand for and know what it looks like. Would they lose a point for acrocyanosis? And you need to know what's normal, because acrocyanosis is normal, but cyanosis around like the lips or on the ears, that's abnormal. So knowing the difference. So periods of apnea, remember that babies breathe in cycles. So if they breathe and then they stop and it's less than 20 seconds, that's fine. That's normal breathing. If it's more than 20 seconds, then that is abnormal breathing. Remember to take the heart rate and the respirations for the full minute instead of the 30 seconds that we're used to. No rectal temperatures, no axillary temperatures. Oh no, do take axillary temperatures, do not take rectal temperatures. Be aware of the reflexes. So I'm not gonna, if you wanna go over them, I can go over them in the Zoom later. But other than that, we have like the Moro, Babinski, rooting, the tonic neck, palmar grasp, the plantar, stepping. Just be aware of those. And then meds, the only medications you're gonna give them are the erythromycin and then vitamin K, and then the hepatitis B. So the erythromycin, you want to protect their eyes. If the mom has any type of STD, that would really impact the baby if they did not have the erythromycin. Vitamin K is to help with their blood formulation, and then hepatitis B, you just want to give that immediately at birth. All right, so common newborn conditions. So these words are really hard to say, so I'm going to try my best. Please bear with me. The caput succedaneum versus the cephalohematoma. So the caput succedaneum, oh my, I can't. I'm sorry. I'm going to say the first one. So that's where the fluid is under the skin. It crosses the suture lines and it's reabsorbed in the first few days. So versus the the cephalohematoma, which is the blood under the periosteum, and it does not cross the suture lines, and that can last several weeks. So hyperbilirubinemia, pathologic versus physiologic. Pathologic, always, if you hear something is pathologic, you know that it is automatically, it's most likely bad. So the hyperbilirubinemia is going to look like that jaundice, that yellow discoloration of the skin and the sclera. And you have that risk of kernicterus, which is that can lead to permanent brain damage. So pathologic is bad, physiologic is okay, and that will resolve itself. The physiologic appears after 24 hours and it disappears within 2 weeks. Pathologic appears within 24 hours and it persists then more than 2 weeks in a term infant. So that conjugated bilirubin is greater than, if they measure it, is greater than 2 milligrams. Causes of this can be hemolytic diseases, ABO incompatibility, so that RH that we talked about before, mom against the baby. So you're just going to want to watch out for that and make sure that you are monitoring those levels, and you're going to want to prevent this, you're going to want to make sure that the mom is taken care of during pregnancy. And then in terms of phototherapy, so that's one of the interventions that you can do. So you maximize the exposure of skin to light, and then the periodic assessment of the serum bilirubin levels, protect the eyes with patches, and then and then you're going to want to measure. Take good skin care and reposition every 2 hours, and then maintain that hydration and nutrition. All right, so hypoglycemia, blood glucose is lower than 40, and that is different than the 60, that if it was an adult, if it's lower than 60, then that's a problem. For a baby, if it's lower than 40, and if it's lower than 30, you're going to want to give IV dextrose 10. Then hypothermia, you want to prevent cold stress. Remember this. You want to remember hypothermia, associate that with cold stress. You just want to do everything within your power to prevent that. All right, so breastfeeding. So the hormones are prolactin and oxytocin. That's recommended for like minimum of 6 months, and this is the gold standard. Newborn should be fed within an hour of birth. And it should be, I would definitely know the frequency. I remember not knowing the frequency at one point. Every 2 to 3 hours, or 8 to 12 times a day. Write that down, do what you can. So the supply meets the demand. For the breast milk, the colostrum should be available within 24 hours, and that's the very nutrient dense. That's the clear yellowish, very concentrated milk. And that's high in the protein and minerals and lower in fat. So that true milk appears about 3 to 5 days after birth and contains that more fat and that whole transition to 100% true milk takes about 10 days. So watch for feeding cues. Oh, actually, says, actually, you don't need to know that. So I'm going to skip over that. Know that prolactin, I'm jumping back a little bit, know that prolactin is released from the anterior pituitary, and it initiates that milk production. And then oxytocin, you definitely need that. You definitely need oxytocin. It's released from the posterior pituitary in response to the sucking. And then you have the milk ejection reflex, or the letdown, the bearing down caused by the contractions of the uterus. So you want to give oxytocin so that uterus is able to contract and shrink back down. Again, delay the bath. They need the vernix in order to be protective. Okay, just jumping back to the slide. Watch for those feeding cues. So hand to mouth, that is a more indicative sign of a feeding cue than that high-pitched crying, because high-pitched crying or crying in general can indicate a lot, but that hand to mouth, that is going to be a very big indicator of feeding cues, of that the baby is hungry. So keep that in mind. Let's see. All right. Remember to do that skin to skin. It's important for many reasons. That both the breast milk and the skin to skin help the baby with thermoregulation to prevent cold stress. Okay. Postpartum. So generally postpartum. So involution is what I talked about on just a second ago. So the uterus should be firm, not boggy, and it should be midline, and it should be at the umbilicus after delivery. And then it decreases in size by 1 centimeter per day, and it should not be palpable by day 10. Um, and then yeah, know the sorry, know the lochia. So we have that dark red, which can last from 3 to 4 days. You definitely want to watch how much in to see if there is postpartum bleeding. So you want to measure and look at that rubra. Serosa is that pinkish brown that should last from 4 to 10 days, and that whitish yellow should last from 10 to 28 days. But when it comes to rubra, you want to look to see how much they're bleeding, because that can you don't want to miss postpartum bleeding, and to check if the uterus is firm or if it's boggy. Um, so yeah, everything heals in about 6 weeks. So baby blues versus postpartum depression, just be aware that baby blues is mild sadness, and it doesn't interfere with care. It is just that general feeling of sadness. But the postpartum depression needs to be diagnosed and screened, and that can happen within the first year. And the feelings are very severe, and it does highly interfere with the mom's relationship and care of the baby. Postpartum complications. So I did just mention it. Hemorrhage. I can't stress how much watching for postpartum hemorrhage is. So that tone is the most common cause. Uterine atony. I don't know how to say it. Atony, but so if the baby was macrosomic, if the body was big, that can cause trauma to the uterus and cause bleeding in the body. The tissue, if that retained the placenta, then that can also cause bleeding. And then if there's no clotting going on. So risk factors for this are high parity, dystocia. If they had a C-section, over distension of the uterus, and that can come from polyhydramnios because it's like overly distended. Placental abruption or placenta previa. And I'm sure you guys know, massage the fundus most definitely if the uterus is boggy. So lacerations, bright red bleeding with so lacerations, if there's bright red bleeding with a firm uterus, I would be aware of that. It's not on here, but know that you are most likely looking at a laceration if there's bright red bleeding with a firm uterus. So signs and symptoms. So if the bleeding, if it's saturating 1 pad or more per hour, if you're looking for that rubra, the blood loss, if it's greater than 500 milliliters for vaginal birth or greater than 1,000 milliliters for cesarean. And you'll also see tachycardia is that early sign. Decreased blood pressure is the late sign. But those are both signs and symptoms of postpartum hemorrhage. But if it asks you which one comes first, it is the tachycardia. All right. And just know for a hematoma, if it is, you're going to see intense pain around the peri area. You're going to see that swelling and blue-black discoloration if it were like a bruise, and there's no bleeding, but there is the change in the vital signs because you don't see it. It's not obvious. It's like internal. It's internal hematoma. It looks like a bruise. All right. So, and I talked about this a little bit. If the fundus is up and to the right and deviated to the right, it's because get a straight cath because the mom, she has a full bladder. Massage the fundus, give those oxytocin medications to get the uterus to come back down because the subinvolution can lead to hemorrhaging as well. Give those fluids to avoid hypotension and replace any blood loss or fluid loss. If there's any lacerations, call the provider for repair, and then for the hematoma, apply ice. Highlight, apply ice, acetaminophen, all that. And to the right are just some of your medications that I would definitely be aware of. You don't have to know the dosage, but know what they are for. So postpartum infection. So that's defined as the presence of a fever of 100.4 for more than 2 successive days of the first 10 postpartum days, not counting the first 24 hours after birth. So there is endometritis. I would just be aware of some of these. So for that, you're going to give IV antibiotics for 24 hours after signs and symptoms disappear. Wound infection from the C-section or episiotomy, UTI from trauma or the Foley, and then mastitis. This one I would focus on inflammation or bacterial infection of the milk duct. Look at the signs and symptoms of that. We have fever, malaise, pain, redness, swelling, or warmth in the breast. And then yes, you can keep breastfeeding if they have mastitis. Possible antibiotics, rest in fluid. You do want to give also that ice and that ibuprofen to decrease that swelling. All right, so high risk. Newborn infection. So remember torch, so toxoplasmosis, there's rubella, there's CMV, there's herpes, HIV. So the mom, remember that for the toxoplasmosis, you want to avoid that, those raw meats and during pregnancy, because that can cause different infections or problems with the fetus. STDs, chlamydia, gonorrhea, hepatitis B, trichomoniasis, syphilis. You want to be aware of those. And then group beta strep. If the person is group beta strep positive, then you want to start you need to get antibiotics. And other rubella, So signs and symptoms: lethargy, poor feeding, hypothermia, or temperature instability. Look for that hypothermia, temperature instability. Focus on that. Respiratory distress, hyperbilirubinemia, cyanosis, pylori, treatment, specific antibiotics, breastfeeding, hydration, and prevention. So most likely you're going to get those antibiotics that the root of the cause needs to be treated immediately. And here's just a picture of things that can happen with the different types of infections. So the preterm newborn. So temperature instability, and we're noticing a pattern here. Usually if there's something wrong, you will see temperature instability or temperature drops. So focus on those. You see resistance. So preterm, they have poor resistance to infection. They have the immature liver and elimination problems, and then sensory perceptual functions. So yeah, you want to make sure you're doing that hand washing and that breastfeeding too, because then that breast milk does have those antibodies that you need. Respiratory distress, lung immaturity. So ideally you'd want to give that betamethasone before delivery to mature the lungs, because that surfactant is needed. Surfactant can be given to the baby after birth, and you do want to give that oxygen therapy to make sure that they don't go into respiratory distress, because that is one of the main causes of death in infants, or in children in general, oxygen problems. So, and problems related to hypoxia, or complications with ventilation. So you're going to see necrotizing encephalitis, and you can see intraventricular hemorrhage, and that can manifest itself as increased intracranial pressure. All right, so hypertensive disorders. We talked about preeclampsia that occurs after 20 weeks. We talked about the we have the proteinuria, we have the, oh my goodness. You're gonna see that raised blood pressure, and then you're gonna see you see elevated blood pressure. Is it edema? Sorry. So preeclampsia. So watch out for that proteinuria, that edema, and that increased blood pressure. I cannot think of it. Eclampsia is that preeclampsia with the seizures. HELP is the hemolytic lysis of the elevated liver enzymes, and it's got the low platelets. And just so you guys know, severe preeclampsia, we talked about those visual disturbances. This is before they're eclamptic, but they could become soon. You're going to see in that increased tendon reflexes and oliguria. The HELP syndrome increases the risk for abruption, because then it's like increasing bleeding. It can cause renal failure, increases the risk for renal failure, hepatic rupture, and then fetal or maternal death. So you want to get that treated right away. And then there's other drugs to treat hypertension, and you want to get on that if you see that their blood pressure is rising immediately, such as hydralazine, nifedipine, labetalol. So treatment, you want to keep them on bed rest. You want to keep them doing as little activities as possible. Magnesium sulfate is used to treat that eclampsia. And remember that reversal for the magnesium sulfate, magnesium toxicity is that calcium gluconate. And then the signs of toxicity are the respiratory depression, no deep tendon reflexes, and low urine output. So other high-risk disorders. So placental abruption, so again, sudden and stormy versus placenta and previa, which is sneaky and quiet. Signs of the abruption is the bored, rigid abdomen. You're gonna have that painful bleeding, and you cannot give a vaginal exam, and you're gonna need to have an immediate delivery. This is a medical emergency. But in both abruption and previa, you're gonna want to give them, most likely deliver them by C-section. So DIC, DIC is mostly caused by an abortion or a miscarriage by that placental abruption infection, sepsis. I would definitely associate DIC with sepsis in your mind, because you can definitely see signs of it. If you see bleeding at the IV site, you can look for signs of sepsis. If blood pressure is going down, be aware of that. Signs of preeclampsia, the molar pregnancy, we talked a little bit about that. You have that prolonged elevated HCG levels. And then ectopic is that sharp abdominal pain. You have those delayed menses. And this is also a medical emergency, and you have a risk of rupture. All right, diabetes. So insulin needs increase as pregnancy progresses, and it drops after delivery. Glucose crosses the placenta, insulin does not. And then with diabetes, you have an increased risk for preeclampsia, infection, and hemorrhage. And then for the fetus, you have increased risk of macrosomia. I've seen this in the clinical setting. If the mom has maternal diabetes or gestational diabetes, you will see that macrosomia and hypoglycemia. So you can also, the intrauterine growth restriction, I'm sure it's there too, but the macrosomia and hypoglycemia I did see for myself. So that is very common. You diagnose with a 1-hour glucose tolerance test at 24 to 26 weeks. And then if those results show up abnormal, then you do a 3-hour glucose tolerance test. But if the blood glucose is reported over 140 after 3 hours, then you are positive for the gestational diabetes. And these people are also associated with higher C-section rates. And you manage diabetes with the diet, the glucose monitoring, sometimes insulin, but not oral ones. And then breastfeeding has an I can't say that word, but basically breastfeeding can lower your blood sugar and regulate that in general. All right, so other endocrine and metabolic disorders, be aware for hyperemesis gravidarum, that you're going to want to replace those. Your priority is fluid and electrolyte imbalance. You're going to want to give those antiemetics, and the symptoms you'll see is like weight loss, dehydration, malnutrition, ketonuria. Be aware of that. And then you're going to want to give those small meals, and make sure you keep them away from really strong smells. Thyroid disorders, medication compliance is key. Hypothyroidism is associated with risk of infertility and miscarriage. And then PKU is that impaired protein metabolism, and you do not breastfeed, and there are newborn screenings to test for this. All right, med-surg disorders. So cardiovascular disorders, more blood volume can exacerbate existing problems and cause cardiac decompensation. And then higher incidence of miscarriage, preterm labor, intrauterine growth restriction, and you're going to talk about genetic counseling. So the increased risk of congenital heart lesions in children with mothers, there is an increased risk of congenital heart lesions in children with mothers and with congenital heart disease. you want to watch out for CPR, making sure there's watching out for choking. So if there's uterine displacement, you place the defibrillators on one rib higher. I would just be aware of this. She doesn't really go too much into this, but just know that you do not do CPR on the actual, you would do it on the chest. You do not do it on the actual uterus if they're pregnant. And then you do CPR if it's ineffective for 4 to 5 minutes. You can also do abdominal thrust performed with the hands in the center of the chest. Okay, so we have anemia. So that's the most common medical disorder. You're going to want to do regular hemoglobin checks. You want around 11 milligrams, and then diet and prenatal vitamins, neurologic disorders, epilepsy. You don't have to know super in depth. I wouldn't focus more on anemia, but in terms, you do want to monitor medications level closely if you want to watch out for toxicity, and if they have too low a dose, they can experience more seizures as a result. And then let's see, MS, common for remission during pregnancy and then exacerbation after the birth. If they're paraplegic, watch for UTI, assisted delivery, altered pain sensation, then PUPPP, that temporary itching so it does not harm the fetus. It is just an annoying thing that that pregnant women can deal with. Also, just so you guys know, UTIs can cause preterm birth or labor. All right, so asthma. So that's the most common respiratory crisis, and it's becoming more and more common. That can change or stay the same during pregnancy. Cystic fibrosis, genetic counseling. That's a main thing you need to know. And they may have a higher risk of gestational diabetes if there's a higher chance of the baby having cystic fibrosis, or if they're carriers. Other things to consider: surgery is safest in the second trimester or after birth. Yeah, I would just know that if there is a trauma, you need to stabilize the mom before the fetus, because the fetus won't survive if the mom doesn't. So you're going to want to prioritize the mom. So common OB medications, we have that Pitocin, we have that Cervidil and Cytotec, which is for that augmentation versus induction. So we talked a little bit about that. You want to get the labor started, and then you want it to progress in the way. So induction is getting labor started. You give that Pitocin. Then you want to make sure that it's maintained throughout. Preterm labor, so terbutaline, you want to make sure that the bleeding is at a minimum. Magnesium sulfate if they might experience preeclampsia, and nifedipine if they're experiencing that high blood pressure, indomethacin, betamethasone, lung maturity. Postpartum, you want to give that Pitocin, make sure that the uterus contracts back down, methergin to control that postpartum bleeding, hemabate to control that postpartum bleeding. And then hypertensive disorders, we talked about that. We give that magnesium sulfate, hydralazine, and labetalol. Okay, so contraception and infertility. So yeah, barrier methods, you have the diaphragm, there's cervical cap, condoms, they require proper use to prevent the STDs. Hormone methods, which is combined or mini progestin, OCP. So the OCPs you need to take, the oral contraceptives, they need to be taken at the same time every day. If you miss one pill, take it as soon as you remember. If you miss 2 pills, take 2 pills for 2 days, using alternative contraceptive for 1 week. If you miss 3 pills, throw out the pack and then use alternative contraceptive for the rest of the cycle. And then for the patch, you want to apply it on the same day apply it on the same day every week for 3 weeks. The ring, so the Nuva ring, you need to change on time. The shot the depot shot, you need to get every 3 months. And then emergency contraception needs to be taken within 72 hours of intercourse. And that's that plan B. And then the IUD. So that's good for 5 years, and then if it's copper, it's good for up to 12 years. You have sterilization if you get a vasectomy or that if you get your tubes tied, and then you have breastfeeding. All right, so infertility. So it can the causes can be male or female, being at an advanced age over 35. You can have ovulation disorders. Um, if you see tubal occlusion, endometriosis, decreased sperm production, obesity, or smoking, such as like or if the mom has an acidic cervical environment, if they have scarring, tumors, STIs, or any other infection, that can also cause infertility. So that's why prevention and recognition of STDs is so important, because you don't want it to lead to that infertility if it reaches or if it gets to a certain point. Male causes hypospadias. That's like where that's where like the hole for the urethra is lower than where it needs to be, so, or low testosterone. And then screening, you want to do detection of ovulation. You want to look at their cycle, their hormone analysis, and then ultrasound, hysteroscopy. We want to look at that uterus. And then male, we could have the sperm analysis and also the ultrasound. And then fertility awareness methods. So the basal body temperature. So that is like the main minimum or baseline the minimum or baseline temperature. If you take your temperature every day, getting out of bed, and the higher, usually if you are ovulating, you will have a higher temperature. And then you want to assess the cervical mucus every day. If it's thinning, then it's ovulating. And then obviously watching to see your cycle on a calendar to see when you start ovulating is a good way to see how fertile you are at the time. All right, so assisted reproductive technology, ovarian stimulation, medications that stimulate the production of follicles, intrauterine insemination. You can have the egg implanted in the actual uterus to have it grow from there, which is in vitro. In vitro is like inside, and then you have these are just different methods. I would just be aware, and then you can donate if you want to, or you can get a donor and gestational or surrogate mother, and then there is adoption. All right, so some practice questions. So for a prenatal patient who is 20 weeks gestation, which of the following labs is an alteration from normal and would require follow-up from the nurse? So the answer is B. So a negative rubella titer means that you do not have immunity. You will need a booster after the delivery. And rubella can cause a miscarriage, stillbirth, and brain defects and deafness. Yeah, and then the VDRL it's a syphilis screening. All right, so a 30-year-old woman with type 1 diabetes comes to the clinical for preconception care. What's the priority of education for her at this time? So achievement of optimal glycemic control at this time is of the utmost importance in preventing congenital anomalies. So good glycemic control significantly reduces the risk, and that would be the highest priority, because it can cause that cold stress, and it can cause that lack of regulation and that macrosomia and a lot of problems for the baby, including congenital anomalies. So the nurse is taking a history on a new prenatal patient. Which of the following would the nurse consider the greatest risk factor for spontaneous preterm birth? So a previous history of a preterm birth. So while these other factors can indicate it, the previous history is the biggest factor contributing to it. So a 24-year-old, Gravida 2, Para 1, woman is being admitted in active labor at 39 weeks gestation. Which prenatal data would be most important to know in your care of the patient at this time? So the answer is B. The patient will need at least 2 doses of antibiotics before delivery to prevent transmission to the newborn. Again, those infections can cause a lot of problems for the baby, and like whether it's they could go blind or affect one of the senses. You want to, if the mom has any sort of infections, you need to address that immediately. All right. So you're working at labor and delivery triage area, and several patients just come in. Which patient should you assess first? So the answer is B. A multiparous patient in active labor with an urge to have a bowel movement will probably give birth imminently. She will need to be first assessed. The provider will need to be notified immediately, and she must be moved to a safe location for the birth. She should not be allowed up to the bathroom at this time. Um, and then, yeah, everyone needs attention, but in terms of who is about to go into labor right at that moment is going to be B, the 22-year-old. So a 19-year-old gravida 1, para 0 patient at 40 weeks gestation who is in labor is being treated with magnesium sulfate for seizure prophylaxis and preeclampsia, which are priority with assessments with this medication. Select all that apply. So the answers are A, C, and D. So you're going to want to check for those DTRs to see where they're at, and I talked a little bit about that earlier. You're going to want to check that respiratory rate. Are they increased breathing, or are they going into that respiratory depression? And then you want to note urine output if they're facing that oliguria. So those are most important. Magnesium sulfate toxicity can cause that respiratory depression and cardiac arrest, so you need to make sure that you monitor that. A 35-year-old gravida 4, para 3 patient who is 9 centimeters dilated with the fetal head at a +2 station. The nurse notes decelerations of the fetal heart tones, which parallel the contractions. The nurse assesses this to be, the answer for this is A, early decels, if they are parallel to the contractions. Yeah, if they are parallel to the contractions or a little bit earlier, these are early decels, and those are fine. All right, a 24-year-old gravida 1, para 0 patient who is receiving Pitocin is in labor at 41 weeks gestation, which was appropriate nursing actions in the presence of late fetal heart decels. Select all that apply. So the answers are A, C, and E. So you want to discontinue the oxytocin. You want to administer oxygen to the mom to make sure that that fetus is getting oxygen, because they might be cut off from their oxygen supply, or they might not be getting enough. And then you want to notify the healthcare provider. If their cord is prolapsed, then they might need to alert the provider that the patient might need surgery at that point in time. So late decels are a big deal. All right, so a 19-year-old gravida 1, para 0 is in active labor and is about to have an epidural inserted in order to prevent the most common complication of this procedure. The nurse is likely to be requested by the anesthesiologist to A, so that you're going to want to rapidly infuse that bolus because you want to make sure you prevent that hypotension. Observing the variability is very important, yes. You want to position the client. If they start seeing changes to the baby, they're going to want to change, like if they actually see the late decels or something like that, or other fetal signs of distress, then you're going to want to change the mom's position. And then teaching the client about the procedure is important, but the priority in terms of the most common complication would be to give those fluids. So you're the RN caring for a 25-year-old gravida 3, para 2 patient in active labor. You've identified late fetal heart decelerations and decreased variability in the fetal heart rate. You've notified the provider on call who feels that the pattern is acceptable. What would your priority be at this time? So you notice those D cells. So the answer is D, is to go up the chain of command and communicate your assessment of the fetal heart rate findings clearly to the next appropriate provider. So it is your job to make sure that the orders that are carried out are best for the baby and best for the mom. You definitely want to get that second opinion, especially if you see those late D cells. Oh my goodness. I don't know why it keeps doing that. So, yeah, but something must be done to immediately address that concern. So you're going to go up the chain of command. So you're the charge nurse on a labor and delivery unit. Which action by a newly graduated RN during a delivery complicated by shoulder dystocia would require immediate intervention? So applying fundal pressure. So we talked about a little bit earlier that applying that suprapubic pressure is, you can do that, but not the fundal pressure because you're actually pressing on their shoulder. So that should never be applied. It may worsen it. The other responses are appropriate actions in the case of shoulder dystocia. Alrighty, you guys. So that is the end. If you have any questions for me, I'm just going to put that Zoom link out there. And I might go over a few other things as well, because I have a study guide of my own. And if you guys want to look over some of that, I can present that to you guys. I can review that with some of you guys as well. Otherwise, good luck and thank you so much for watching.